how long does it take to do all that screening?
Oh, that's a great question too.
I understand that there's nuances based on how basically detailed you have to get in it, but for the uncomplicated case down to
Sure.
It takes the amount of time to give 2 packed RBCs.
So from the time
that's the time it takes for you to get nervous.
Yes.
Where's the rest of my blood?
from the time that you get a type and screen
Yeah.
into our hands, if we're doing it by hand or putting it on our machine by itself, as long as there's no antibodies and there's nothing weird coming up with their blood type, it's typically about 30 to 35 minutes before all the testing's done on that type and screen. You give us that second ABO, we're only doing the blood type on that. If we're doing it at the bench, from the time we process it, spin it down to separate the plasma from the red cells, we're typically looking at 10 minutes. Okay. Electronic cross-match, minutes. It's
Got it.
super fast. That's one of the reasons that...
Is that whole blood that they do testing on? It has to be spun down too?
So when you when you get the collection and they spin it down, so the red cells then have what they call segments on it. So they use the plastic, it's not plastic tubing, but for lack of a better word, the tubing comes off the whole blood collection, and then they kind of heat seal them, so then we can take a segment off of the whole blood, and then so it's packed cells, so you're just getting the antigens on there.
Okay.
And
They call it the donor tails.
Yeah.
Yeah.
Oh, okay.
Yeah, so even when you have those 2 units in your blood fridge at Portage,
Yep.
when you go to take it and that unit ends up discarded, we keep little segments off of those so they can do the retrospective testing after. So all the testing, it's not happening as you're transfusing just because of that scenario.
Sure.
But it still gets done.
It still gets done after the fact.
Yeah.
Yeah.
And that's all for patient safety, right?
Yeah.
Yes.
Absolutely. So we'll just break this down real quick. We are regulated by multiple facilities. University Hospital is DNV. We used to be JCO. So as a lab, a blood bank lab, we are also regulated by the Federal Drug Administration. We have voluntarily been regulated by AABB, which is like the gold standard of blood banking. And then we also fall under CAP regulations, which is the University Hospital has voluntarily submitted ourselves to as a lab for CAP, College of Pathologists. So those regulations are what determines how we perform our testing, and then we have to validate towards that. So we try to meet those gold standards, and the expectation is you get 2 types on file, and then you have to perform some kind of a cross match before you can say this was acceptable. Yeah. Now, to follow up, when the screen's not negative or you have a history.
My favorite part.
Yeah. Ideally, it could take 3 hours if it's a simple thing. Yeah. We do have some patients that there's only 3 people in the entire world that are negative for that. So if we wanted to try to get one of those donors, it could be weeks.
Wow.
So it really just depends. Most of the common antibodies we're able to do in-house or get them from our blood suppliers and then get them to you. So once that pops positive, there's going to be a call and be like, hey, something happens. Might want to slow down a little bit. We can try to get you something at least antigen confirmed before we finish the testing. So once you pop positive, it could be hours, days, weeks before a compatible blood product is available.
I had one recently. It probably took almost 48 hours for us to get blood product that was appropriate for the patient before they could get transfused. So it does happen. It's not even a rare occurrence. I'm sure you guys see it daily.
Yeah. We have certain patients, like it's also another podcast, but there's certain drugs out there now that are miracle drugs that it kind of gums up our testing.
All the mAbs.
Oh.
Yeah, daratumumab. It's
Magrolimab, Magrolimab, sorry.
Yeah. So the CD38, CD47s, it's all stuff that extra testing has to be done that gets set out, and their turnaround times, a day, and then we have to cross-match and everything else. And is that patient bleeding? Are they stable? Every step of the way, not just from the communication to you guys, but to our reference labs that we utilize, it's all about communication. Let us know what your patient status is. Is this one that needs to jump to the top of the line? Is this a patient who, could potentially go home first thing in the morning and they're...
We'll call you when we have product available for you.
Yeah.
And that's where our team
Outpatient
attendings come in. So the nice thing about at least main campus is our transfusion medicine attendings are transfusion certified. And so that's when you will have that conversation, be like, is it worth transfusing this patient in this emergent need? or is it best that I just do something else?
Yeah. Well, I think that leads perfectly into, because we talk about how it's difficult to sometimes get special products. Where do we get our blood products from?
Yeah, you talked about suppliers a minute ago. It's
Yes.
is there just a business where people have this on the shelf?
I mean, I'm going to say yes, but not in this region. So we do have the capabilities of having what they call paid donors or volunteer donors. So in Northeast Ohio, the expectation is a volunteer donor. Now, I will tell you, we get a lot of not a lot, but it will happen every once in a while. A person be like, I want to donate my blood, but I don't want to have anybody pay for it and all that stuff. And it's like, well, that's not how that works. So when we say something is a volunteer collection, it means you are going in with no expectation of getting reimbursed for that.
Yeah.
You know, like some of those plasma sites where you get money. This is not what the blood center is asking. They're asking you to just go in and donate. But then we also have to cover the cost of all the infectious disease testing that's being done and so forth. So that's where the paid product comes, and that's a invoice to me.
Yeah.
But the donor is giving willingly of their blood, whether it's a whole blood collection where it's just in the one arm, maybe 20 minutes and you're gone after you get your cookies and juice, or you have your apheresis collections. So you have your double reds and your platelet apheresis. But again, it's all volunteer. I'm willingly going in here with no expectation. Sometimes they run, get a t-shirt, get a gift card, and that's fine, but it's not considered paid.
Sure.
So I know out in California, because one of our blood suppliers is asking us, they do have what they call the paid donor. So there's a little more, do you really want to with that? But that's the two different ways. So you either paid, which is, like I said, out in California as far as I know, but in Northeast Ohio, it's a volunteer. I just want to do this because that's the right thing to do.
Yeah. Why don't you talk about double reds? What does that mean?
So double reds, normally you'll go in first and you'll do a whole blood collection because they don't know what your blood type is. There's certain blood types that we really don't want you for red cells. They're about 1% of my donor population
and
that are
to be
ABs.
fair, it's because, as we talked about red cells versus plasma, right? So I want your yellow stuff, as I call it.
Yeah.
I want your yellow stuff. So
Not urine.
yeah, not urine.
Okay.
I want your plasma, your platelets, your cryo. So that's your yellow colors versus your red stuff. So
yeah. So you go in, you donate. They are going to do your blood type there as well. So they see that you're an O. We want O's. O's can go to anybody.
Sure.
So they're going to call you up and say, hey, how about next time when you come in, you sit in my chair, and we're going to hook you up to this machine, and they can get, they call them power reds now, but they will do 2 bags of red cells and give you back your plasma and your platelets and everything else.
The stuff they don't want.
Yeah.
Yeah.
Basically. For the platelet donors, it's the same thing. They see that you're an AB. We want your AB platelets.
Yep.
That's what I give to my little neonate kiddos.
Yeah.
Like my 1 kilo kiddo, that's the product I want. So they're going to come in, hope you have a high enough platelet count, and we can get 2 or 3 bags out of you at a time. So you can help a lot of patients. That's a very precious resource, especially with how short the lifespan of a platelet product is, to identify those people who are willing to do that collection. That's very important.
I guess talk a little bit about that lifespan of all of the various products. Is it
Sure.
I donate today. How long is
What's
it?
that look like?
Yeah.
Yeah.
How long is it available to you? How long is it available for him and in his refrigerator?
Yeah. So if we go in and we do that initial whole blood collection, it depends on the additive that it's going to be stored in. Some of the additives are short as 21 days. We've got 35-day outdates, and I think they have a 42 now. Yeah. So there's a varying scope of those. When they take off your plasma, because we're breaking down that whole blood donation, and we freeze the plasma, the frozen product itself can be good for a year.
Oh.
So we have a little more time, and that's very precious time. Once we thaw that product, because that MTP does come in, and we get the okay to go, let's throw all this in the thaw, we have 5 days for a plasma product. For platelets, when they come in, right now we aren't getting platelets from a whole blood collection. I know that there are some out there still that are getting pooled and dispersed, but our region strictly right now for our group is pheresis collections. So there's a 5-day out date, which are our PR platelets, and then the 7-day LVDSs. So when those come to us, we don't have that whole 7 days or 5 days even. We're waiting for all that infectious disease testing to be completed.
Sure.
So by the time that we get the product in our blood bank and we're signing it in, getting it ready for your patient, sometimes we have as short as 36 hours.
Wow.
So I think one of the big things that we do, and we monitor our wastage very closely, is we're looking at, what days do we need the product? Okay, I don't have these clinics on the weekend.
Historic usage.
So this is all stuff that we evaluate constantly to try and protect our inventory and to help the other hospitals in our system. It's a very fine line. That plasma, like she said, you can also process it and make cryoprecipitate. So again, a frozen product where you have that year out date. But when you thaw it, we're looking at 6 hours for a pre-pooled product.
Yeah.
If we open up the system and pool a bunch of units together ourselves, we're looking at 4 hours. So it's very precious. It's very time sensitive, I think is a nice way to put it. The communication that needs to occur for some of these products is very tight.
So, and excuse my ignorance here, but let's say from familiar with the concept of the mass transfusion protocol and stuff like that, but how do you have that stuff thawed and ready to go?
Yeah.
I can't imagine that, you've got a shot counter on the top of it, like, oh, there's 3 more, and start thawing some stuff out. We got somebody coming in. But are you always buffering a little bit, basically following the trauma patterns in Cleveland? Or
yes
wherever.
and no. Yeah. So, like I said, being main campus, a level 1 trauma center for both adults and peds, we, like Dr. Hill said, have a fridge in the ED. Yeah. So that fridge in the ED is going to help both adults and peds. So we want to make sure that things are O negative and AB plasma. So we rotate out O negs and AB plasma. AB plasma, we take it out on the 4th day. It's only good for 5. So on day 4, we're trying to find somebody else to use it within the hospital.
Sure.
But we're cycling that out all day long. And then in the blood bank itself, we have a rolling stock of, like I said, we can give adults A plasma. Yeah. So we have a rolling stock of A plasma thawed, ready to go for that first cooler. So when we think thawing, it's not like you put it in the microwave and, hit the defrost.
Sure, of course.
So
I thought that's what happened.
See?
They tried that once. It did not work.
Yeah.
You get scrambled eggs.
And that's it. You don't want to thaw plasma too hot because then it's albumin-like, and then you have the scrambled egg or white yolk-looking stuff. So we have to thaw at 36 degrees Celsius, and we thaw that at a warm water bath and then agitate. So even a small volume plasma is going to take about 18 to 20 minutes to thaw before we can give it to you. So being a level 1 trauma center, it makes sense to us to rotate active plasma to get that first cooler of MTP out the door for you. So yeah, we are kind of just always at the ready to start a trauma. Which is exciting because we're blood bankers and we're weird like that. So that's what we live for.
Sounds like you spend your day just moving shells around. You're like, oh, no, use this over here. No.
Yeah.
We do. It's on our checklist,
Shell A goes to
grocery store. Just redo the stock. First in, first out.
Just rotate. Yeah.
So they hit the door downstairs. They clean out our fridge down there. By the time that they come upstairs to our OR, we have that shelf, like she said, with the 10 next O-negs to go out and the 5 A plasma and 3 ABs for our kiddos. So that second set of MTP is ready to roll too. So by the time you've depleted both of those, our thawers, they can do 8 at a time. So we're running 16 units once that MTP call comes. So we can keep up, but that initial buffer is really important.
Yeah, that's what I had in mind.
Yeah, because most MTPs will be good if we get to cooler number 3, but we have, being a big facility as we are, 16, 18 coolers have gone out of door before they've deactivated MTP. Yeah. So that's like all you're doing all day is thawing and setting and issuing out product. So that's keeps us busy and it's fun.
Yeah. It's nice too because we have a good rapport with a lot of our surgeons, anesthesia, and they do come to the window themselves at the end and bring us back a cooler, and they're like, we're good. And hearing that, you can see everybody. 'Cause we run like 7 or 8 people on days,
Sure.
3, sometimes 4 at nights. You can see everybody just go, whew. Like it's almost like catharsis. Like you're
Yeah.
just
you
let
did
it all
something
out.
good today.
Yeah.
Yeah.
I can go home and eat that, junk food that I wanted. And
Yeah.
I
Lots
already
of
ran it
stress
off in the
eating.
blood bank. Yeah.
Stress eating for sure.
Well, and it's funny. We had Colin McCloskey on. He actually his podcast is going on now this month.
This month, yeah.
And one of his sentences he said is, critical care is just time at a cost, right?
Mm-hmm.
And that's what you guys do too. You're spending a lot of time and a lot of money and a lot of very important product to help keep these patients alive. You're an integral part in that chain of life, for a better turn of phrase, and caring for these trauma patients, hemophiliacs, whatever their condition is, OB patients, right? I'm sure you guys do a lot of like blood products for OBs. GI bleeds are the big
Solid
medical
organ
cause.
transplant.
Yeah.
I mean, so at the academic facility, just so everybody's, when you donate blood, you're not just helping that cancer patient or that trauma patient. At University Hospital Cleveland, we have solid organ that's going to need your blood. We have neonates that are going to need your blood. We have pediatric and adult oncology patients. We have our sickle cell population. We are the place to go in Northeast Ohio for your sickle cell needs and so forth. So there's a lot of different people outside of, as we talk about trauma, that need that whole blood collection. So it's always a need. It's always an ask. And, you'll see it on the news and you'll hear us say it 20 more times in this podcast, I'm sure, that go donate. So.
Yeah. And I guess on that topic, we've not said anything in stone yet, but by the time you guys are hearing and watching this podcast,
Hopefully. Yeah.
yes, we're starting to partner with blood collection people. Suppliers, thank you.
Yeah.
Blood suppliers to do
Vampires, yeah.
a blood drive near you. So that's in the works. If you're hearing this, look for that. We're going to probably run that all year round and probably do some competition
Yeah, absolutely.
between the hospitals, whether that's Portage versus Geauga or whatnot, to see who can get the most people to come out and support your local fire departments, right? So check back for that. But again, moving on, one of the big reasons why I wanted to do this podcast is Ohio changed the rules and increased or added to scope of practice to paramedics to start these blood transfusions in June of 2024. And University Hospitals, as part of that, started looking into the possibility of getting blood products kind of more out into the field, and working with our partners with Cleveland Clinic as well as Metro Health in the Cleveland area to work on a program. And I know you guys have been involved in this a lot, looking at other EMS agencies throughout the United States. They seem to focus on whole blood. Sure. Whole blood has its issues. You want to talk about how long whole blood lasts versus the components?
Yeah, so to be clear, when we talk about whole blood, we are just taking that whole blood, that donation you just gave, not an apheresis, power red, or anything, and we are just putting a label on it and saying, here you go. So we're not spinning it. We're not doing anything. We're not even adding additive. So because we're not adding additive, that bag is only going to be good for 21 days. And then if we provide different product, which is a liquid plasma, which I'm sure we'll talk about, that's a whole blood collection that has the plasma available. It's only good for 26 days. So when we talk about whole blood, the first thing as a blood bank manager is wastage. Yeah. So the concept of having whole blood out in the field, nobody's saying that that's not a good idea. But because we are regulated by the FDA says, well, this is good for X, Y, and Z. And X, Y, and Z are trauma, and trauma, right? So if you're not using it in the field and you bring it back to me, I can't just use it on the cancer patient. I can't just use it for the sickle cell patient. So we have to think about the business side of things. So whole blood overall has its pros and its cons, and one of the biggest cons that I see in it is wastage. As far as that concept of if you don't use it, who's going to use it?
Who's going to use it?
And you guys, we don't even use whole blood now in the hospital
Correct.
setting. So
Yes.
it'd be a change for us to be able to even adopt that whole blood. I know that other places have talked about then taking that whole blood back and then spinning it down. But then
Well, that was the
Yeah.
that was the whole conversation
was-
on one. So just take it back and break it down and use it wherever you want. It's not that easy,
it's,
is it?
It's not that easy because we're FDA regulated, we have to have a license, and
silly,
when you do
silly
that,
rules to keep people safe. I
right,
know.
that crazy license, there's quality measures that Matt doesn't want to have to worry about in his life to make sure that that product then is acceptable to use.
Right.
So to just say, oh, I'm just going back to the hospital, they'll spin it down and use it in its components, that's not going to happen. Now the blood centers can do that. You know, if I don't need that whole blood product, then at some point they'll be told, fine, their hires up, just spin it down and it's still good. But they have the license to do that. I can't manipulate that product, and the blood center isn't going to take that product back to do that for me. So it's whole blood when I get it, when you get it, and when I get it back, and that's where it ends.
So you mentioned liquid plasma.
Yes.
So one of the things we're looking at is red blood cells plus liquid plasma.
Correct.
Want to talk about liquid plasma at all?
So liquid plasma, it's that I'll say broken down product again from the whole blood, but it's never being frozen. So it's not going to have that 5-day expiration. It's just going to live refrigerated for 26 days.
Yeah, it's funny. It's 26 days, but they always say it's 21 plus 5. Whole blood.
Yeah.
I'm like, what is? It's 26 days. Is it not 21 plus 5?
Yeah.
It's always 26.
I haven't taken a math class in a long time, but I think that sounds
Unless
right.
it's
I don't know.
February and it's a leap year.
Right.
then
Yeah,
it's
right.
Yeah.
Then you lose
Yeah.
a day
Yeah.
Yeah.
or gain a day.
So that's a product that it's something that we are taking a peek at just because it's a little more, I guess, friendly for a trauma situation. I don't have to worry about thawing it. I can just have it in my fridge with the rest of the red cells in my walk-in and grab those and out the door they go. But again, it's all a guessing game. How much product am I bringing in versus how many am I using? Is it winter when I'm not seeing as many of these incidences? Is it, summer when, I have a whole rash of shootings that are going on? Some nights we have 8 pages that go off that are all gunshots, and some nights are completely quiet.
Or it just might be a mass casualty incident that we don't know about.
Yep.
No big
Yep.
deal. But the thing with liquid plasma, the good thing is that's something that, like I said, when we think about whole blood and liquid plasma, it goes out to the community and it's going to come back to me. If I get liquid plasma back, first off, you don't have to see me every 3 days because I'm going to want to recycle that plasma and try to get rid of it. But if I have liquid plasma, you probably won't have to see me until probably day 21 or 22 and then say, hey, I need some better outdated stuff.
Right.
What little we've looked about liquid plasma, we could then potentially use it on other patients in the hospital. It's not just trauma with the liquid plasma. So we might have a better chance of not wasting the liquid plasma. And then, like I said, the EMS don't have to look at us every 3 days.
Yeah, I really feel bad when AirMed has to come in and replace their blood unit.
Sure.
That can't be fun visiting us because we're not their base.
Yeah.
No, they're there enough.
That's what we figured. It's like, oh, we just dropped somebody off, so we thought we'd just swing by and switch this out real quick.
Yeah.
That's fine.
But yeah, just to put a high level cap on what you said, like the whole pre-hospital usage thing comes down to logistics.
Yep.
Is how do you store it? How do you store it safely? How do you exchange it? And
Who do you use it on?
who
What type do you give out?
fundamentally we can protocolize that, but
Yeah.
it's I think for everybody's like, oh, we can do this now. This is going to be easy. We're just gonna have a Coleman cooler on and everything's great. It's not that easy. There's all that regulatory back end stuff, and the precious commodity. We can't be cavalier with with it, right? Again, being good stewards of the product.
Yeah, even just in our blood bank, our refrigerators have to have a serial number.
Yeah.
Or something that we call them. They have to have all these quality controls that go into it before we start them. Are they monitoring the temperature 24/7? Is there a backup to it? Is there a battery?
Is there a backup to the backup?
Yeah, is there a generator?
Is there an alarm?
Yeah, so everything that we test at startup, if it goes down, we have to make sure that it works again once it's fixed. Quarterly, you have to do these checks if you want to have a cooler, like you said, the Colemans. How long does that thing hold temperature for if it's just a bag of ice that's going in there? you know, prove it to me that it can do it repeatedly.
Right.
Are we going to bring in a nice little refrigerated unit for the rigs or the chaser cars or supervisory vehicles? How long is that thing good for? Is it a battery backup? Is it ice pack inserts? There's so many little nuances
Variables, yeah.
that it's kind of neat to see everybody communicate on when we're in these meetings. But just seeing, okay, well, this thing has to get shipped out now because it's at its 1 year mark or its quarterly check or something like that.
Right. Yeah.
It's incredible what goes into every little detail just to put 2 units of blood somewhere.
What other challenges do you guys see with even just giving blood to AirMed or to, let's say, critical care ambulance? Like, what other challenges are there that we haven't talked about?
Yeah, let's go back to Blood Bank 101 about that O-neg, that pesky 7% donor collection,
Sure.
right? We, like you said, we like to make sure that Rh negative people, specifically females and children, only get Rh negative product. But when you have a person walking in your door taking 16 times 5, 60 units at you, you can't support them with O-negs. So we got to look at other things. Again, the Rh negative we know is not the first reason you're going to start having transfusion reactions. We were really focusing on the ABO. So again, wonderful DOD, O-pos, red cells. So when we are in situations where we have our O-negs depleted, which unfortunately happens quite regularly, we put ourselves on O-neg mitigation. So we start identifying those populations that it's like, do you really need the O-neg or can I give you the O-pos?
Can you give pause? Yeah.
So we have practices in place, males, older females that are no longer childbearing age, where we can give those O-pos red cells. And so we have to think about that in a trauma situation when we talk about this. Can Northeast Ohio supply X amount of ambulances with O-neg red cells? Probably not. We just got a notice from one of our blood suppliers that O-neg donations are down. We're going to have to start, button up our bootstraps kind of thing and get out there and find some. So we have to talk about giving O-pos red cells in a trauma situation and what does that look like.
And patient selectivity, yeah.
Yes, and especially when you're out in the field, it's like, are you not going to give that female the red cell because there are no pause? Yeah. No, but we need to think about those things. Because once you give it, obviously you'd hope that the ED doctor heard you when you said, hey, I transfused red cells in the field. But what if he didn't because he's kind of busy doing other things trying to save the patient? How do we document that? How do we follow that patient? How do we make sure that they're okay afterwards? And the appropriate post-after action reporting and medications are given.
Or in testing, right? Because
Yeah.
we talked about testing the blood that we gave to the patient, even if we best guess this is what you need. Now I have your blood sample, and I'm going to take a sample of the blood I gave you and make sure that we didn't screw something up. And if they did have an antibody, how do I get ahead of that to help? So that way, because the worst thing that happens is we send them into like some terrible hemolytic reaction, and then they have a bad outcome because of the drug I gave them, which was just happened to be O-negative blood.
Yep, exactly.
At the same time, we also have to make sure that that patient even makes it to the hospital
Sure.
to get that tested.
Absolutely.
So it's one of those.
It's a balance, right?
Yeah, weigh it. If you don't give the blood, I'm not going to have anybody to test.
Sure.
Yeah, on some of these calls, I'm glad that there's been the recognition from the medical directors at large that, if we're going to start standing up these pre-hospital programs and doing regional response cars or going beyond what, at least in this area, is really just kind of reserved for the aeromedical piece, right? Because we can, of course, deploy to a much larger radius from our air bases than we can by ground. But there's been the recognition of we have to be part of the collection. We have to be beating the drama of, getting donors and turning to our own source, right? Is getting our departments and our personnel to be part of this if we're going to be consuming them on the same patients, right? It's not, we can't just operate in a vacuum and be like, gimme. It's, we have to be part of that solution as well. So, and I've been very proud of, again, most of the doctors have recognized and have, spoken to that on these meetings that, like, hey, we need to, there's more to this. It's not just, not just be the consumer.
One of the big challenges is making sure we have enough blood in the pipeline to be able to support
to do the thing, right?
This.
Yeah.
Exactly.